A very good evening to one and all. I am Arpita from the IGCP group. The topic that we are going to deliver today is management of cervical dilution. And yes, to address the
Dilatation.
topic, we have with us someone very eminent and an expert in this field, none other than Professor Dr. Madhulata Alexander, ma'am. It's an honor for me to welcome ma'am and to introduce her to everyone. Ma'am has done MBBS, post that she has done MD in obstetrics and gynecology. She is a professor at Osmania Medical College, Hyderabad. So, ma'am, with this very brief introduction of yours, now I would request you to please go ahead with the presentation. Over to you, ma'am.
Yeah. Thank you, Arpita. See, actually, it is not dilution, it's dilatation. Management of cervical dilatation, or it is called also cervical insufficiency. I think we as obstetricians, it's quite a nightmare for us to deal with this problem, but it does come forth day in and day out. In fact, yesterday itself we have done a surgery, but we are having side complications with that patient. I'll come up. It's an abdominal circlage what we did, but we had some complications, and unfortunately we are losing the baby. Okay. Now, what I'll just go briefly about what is the cervix. Now, the uterus, as you know, the uterus, the main part of the uterus, is made up of muscle fibers. That's why after the baby is born, the uterus contracts so that you get the uterus becomes a hard ball, so you won't get PPH or you won't have bleeding. But what happens to the cervix? It is the part of the uterus that's the lower part. It is not made of mainly of fiber, of muscular fibers. It's mainly made up of fibers, collagen. It's made of collagen mainly. And the ectocervix is that portion that connects to the vulva. And the external, it depends on the shape and size, depends on whether you had a baby or not. And in pregnancy, normally the size of the length of the cervix is about 4 centimeters plus or minus 1. That is normal. Now, the incidence of cervical incompetence is about 1% of the total obstetric population. About 15 to 20% of miscarriages that occur between 16 and 24 weeks are believed stem from this etiology. That is why it has gained significance. Okay, what exactly is the definition of cervical incompetence, which leads to cervical dilatation? It's a condition in pregnancy where the cervix begins to dilate, not because of contractions, what happens in normal labor, but due to structural weakness in the cervix itself. It is also the inability to hold the weight of the pregnancy, that is, the bulging, the amniotic membranes bulge into the vagina. There's rupture of membranes, preterm labor leading to fetal loss. Usually, what happens, the history of the patient gives is there'll be second or early third trimester fetal loss with painless cervical dilatation. Usually, this occurs in the second trimester. What are the various risk factors? Just recap: recurrent second trimester losses, history of incompetent cervix with a previous pregnancy, any cervical injury, multiple DNCs, repeated traumas because of cerclages. Our patient yesterday, as I told you, had that, repeated pregnancy terminations, biopsies, cone biopsies, cauterizations, anatomical abnormalities of the cervix, diethyl stibestol exposure, which nowadays we hardly see it, and also connective tissue disorders like Ehlers-Danlos syndrome. When we diagnose this, we usually don't rely on the traditional abdominal ultrasound to diagnose this, because even if we do a traditional ultrasound to diagnose this in early pregnancy, the bladder has to be filled. And sometimes this can lead to elongation of the cervix, and it can mask any problem or any funnelling of the internal orb, which I'll come to later. The fetal parts can obscure the cervix, especially after 20 weeks. And the distance from the probe to the cervix the image may not be so good, and obesity and manual pressure interfere with the image. How do you diagnose? Many people can say, oh, we can diagnose with a digital examination. No, digital examination is very subjective. It's not reproducible. Some people, obstetricians may say this is a short cervix, this is a long cervix, this is a normal cervix. No, the transvaginal ultrasound is the gold standard for measuring the cervix nowadays. It's more reproducible, and we measure the cervical length from the internal os to external os along the endocervical canal. We take about 3 measurements with the calipers, and the shortest recorded best measurement is recorded in millimeters. And after we take the millimeter, we apply the fundal pressure for about 15 seconds to observe any changes in the length of a funneling. The length of the closed cervix or functional cervix, it is the most useful predictable measure to predict preterm birth. Why we don't do it before 14 weeks is the lower segment is difficult to distinguish from the endocervical canal because the gestation sac is not a sufficient size. Therefore, measurement of true cervical length is often difficult before 14 weeks. What about the TVS, transvaginal ultrasound? It can measure the cervical length less than 25 millimeters. The best time to measure is between 16 and 24 weeks. It's the most reliable threshold associated with increased risk of preterm birth. Now, should we go on squeezing a patient? When is the frequency? It depends upon the patient's history. And if you're suspecting a patient who is high risk or more in chance of getting a cervical incompetence, then a better one is better predictive accuracy than a single evaluation. And see, when the radiologists have so many criteria on the right side, all these they have to do to measure the cervix. How they measure basically from internal to external os along the endocervical canal, and if sometimes cervical canal is curved, so you take two measurements and add them two together. Usually, when you have a short cervix, it's usually straight, but a curved cervix generally signifies uh, a cervical length of more than 2.5 centimeters. So, generally, a cervix sort of rules out a cervical incompetence. Now, how you measure? Normally, when you measure a cervical length, it looks like this T shape. On the right side, there are four images. Now, the normal one is T, where the lower segment, the cervix is long and it looks like a T. It's a sagittal view, looks like a T. Now, what happens when the cervix begins to become incompetent or it's not okay? Then the internal os starts to dilate first. So it looks like a Y, then becomes a V, and then a U. Now, this is a normal, this is a basic, the ultrasound pictures translated. On the left side, the normal cervix. You can sort of imagine the T, but the cervical canal is long. On the right side, it looks like a funnel. The dark area is the funnel, and this is what happens when there is cervical incompetence. Now, when do you screen? Patients are going to ask us when to screen because the patient is anxious. The most common gestation age when we screen is from 18 to 22 weeks. And as I told you, there is no hard and fast rule about when exactly you should measure, how frequently you should measure. But if the patient has high risk, you can diagnose these short cervical length earlier, and also in case you do about two cervical measurements, one between 14 and 18, and the other between 18 to 22. If the cervical length is at least 2.5 or more, it is sort of reassuring. Now, symptoms. If a patient presents with at least cervical dilatation, internal loss is 2 centimeters or more, she may have minimal symptoms. But once it reaches 4 centimeters, she may have contractions and rupture of membranes. How it should be managed? Managed should be case based. Each case should be managed individually and determined by the prior history. TVS assessments in low risk patients can be used to screen. Serial ultrasound in high risk patients every 2 weeks, and it should initiate between little earlier, between 16 to 20 weeks. And in these patients, you can sort of tighten that internal loss by giving a cerclage, or that is give a sort of a thread that goes around the cervix and sort of tightens it. Now, if a person, this is a good flow chart, if a person has a prior history suggestive of insufficiency, if she has history of 3 or more mid-trimester losses, think of vaginal cerclage. If she had repeated cerclage which has failed, think of abdominal cerclage. Okay. Now, in case she had only 1 or 2 mid-trimester losses or a preterm birth, evaluate. You are justified in doing experiment management and measuring the cervical length serially. But if the cervical length is below 2.5 centimeters at all at 24 weeks, you don't always have to think of cerclage. Think also of progesterone. We are managing many patients with progesterone. There is no need to cerclage in every case. But if the cervix is more than 1 centimeter dilated, the internal os, if there is no infection, if there is no chorioamnitis, consider emergency or rescue cerclage or steroids. Suppose you are thinking of delivering the patient, think of steroids. And if the contraction manages a certain term labor, you have to think of termination. Or sometimes you have to give tocolysis just for the steroids to act, then you have to terminate. So when you do the cerclage, when you do elective cerclage, when there's congenital defects, when there's the classical features, when there's history of 3 or more, painless cervical dilatation trauma or excessive force cervical dilatation. Now, this is a very good picture. Now, this on the right side, this is a drawn picture. Now, this is the cervical length. If you do a vaginal circlage, that is the common one, what we do, the McDonald's, we do it here. Okay, this is here, and we're doing it here, McDonald's. So that's why it's not always successful. The shortcuts one a little higher than this, but it is not at the level of internal laws. That is, you open the flaps, vaginal flaps, and you put it at a higher level, as high as you can. But this is not at the ischemic level. If you do it, it's the best. Like, see that. See, this is the cervix. What we're doing from the vaginal approach is only somewhere along this. But if you do abdominal approach, it is here and better than the vaginal approach, definitely. Abdominal circlage is what we commonly do. Here we are holding the anterior lip. We are putting the circlage, the thread goes like this, and we take birth 4 all around and put the knots here. Okay. Modified serological is here you're opening the vaginal flaps. You're putting the cervical suture and putting it here, you're putting it higher. This is supposed to have better results, but there are also problems with it. Now, what advantage of abdominal cerclage? When you have a prior failed vaginal cerclage, where you're not able to do it, improved birth outcome, the transvaginal cerclage. Therefore, you are justified in doing abdominal cerclage. Now, if you do a vaginal cerclage, the threads will be in the vagina. So, therefore, it's a sort of nidus for infection. This may lead to preterm labor or PR, preterm rupture of membranes. How do you do it? We do it by laparoscopy. I'll show you the next picture. This is a very beautiful picture. Nowadays, we're doing all by laparoscopy. You can either do it when the patient is pregnant. Our patient was pregnant, but this laparoscopic, what we are normally doing nowadays is we're doing it inter-pregnancy, in between pregnancies. You go to the laparoscope, you open up the UV, you put the tape here. It is identified below the the this you identify the uterocycles, go above it, and you go medial to the uterine artery. That's the best way of doing it, and this is what we have done yesterday. But as I told you, it is not very successful. But what is recommended now is do it in between pregnancies, okay, and ask her to conceive after 8 weeks, and in case the patient wants to have more children, she is allowed to keep the cerclage in situ. And after when she's having undergoing tubectomy, then remove the cerclage permanently. Okay, you're justified in doing that. Rescue cerclage is another cerclage in which the membranes will be prolapsed, like there'll be premature cervical dilatation and exposed. These are usually in emergency situations where we do a rescue cerclage. What we do is you can either diagnose it like this, it can be beautifully diagnosed like this, where you can see the membranes bulging through, or it can also be diagnosed by ultrasound. You have to put the patient head low, put a Foley's in the cervix, slowly inflate it so that the membranes go back into the uterus, and put a circlage, a McDonald's from below. It we are doing it in certain bigger centers. It can be considered up to 27 plus 6 weeks gestation. And so far, whatever results they have shown is it can delay the birth up to 34 days. So you are getting about 34 1 month, you're getting more the baby. And then after the neonatologist can take over and manage the baby. Now, there are a lot of questions asked. There's no literature to support this. Patients will ask you, should I have perfect bed rest necessary after cerclage? Yes, it is advised. But what is said is abdominal cerclage is no need of total bed rest, but there are no studies to support it. Sexual activity, there are no studies about it. And also twins, there is no need of routine cerclage for twins. Until more data is available, the use of cerclage in nulliparous women, that women who didn't have children and who have no history of preterm births, there is no necessity of putting a cerclage, even if they have other risk factors of preterm delivery. What are contraindications of when you remove a cerclage? When there's bleeding, ruptured membranes, or uterine contractions. Complications when the suture disruption, rupture of membranes, etc. And the correct time for removal is unclear, but generally we remove it around 37 weeks. Thank you. Arpita?
Yes, ma'am. Yeah. Just a minute.
Yeah. Are there any questions, Ma?
Yes, ma'am. There are questions from the audiences. Ma'am, am I clearly audible to you?
Yeah, I can hear you clearly. Yes.
Right, ma'am. Ma'am, thank you, ma'am. Thank you so much for the presentation. Now, we have received a few questions from the audiences. Ma'am, the first question is that what are the key indicators for initiating cervical dilatation during labor, and how do you decide the appropriate timing?
No, no. I think key indicators for deciding cervical cerclage. I think that's what you mean. When do you put a cerclage? Okay. Cerclage is done only if the patient is definitely having a clear history of cervical insufficiency. Okay. Now, usually when the patient has about cervical loss, three pregnancy losses, okay, or there's definite trauma, or there is clear-cut ultrasound indications, then we put cerclage. But as I said, at least three pregnancy losses suggestive of preterm birth is important. Now, if a patient is nulliparous, that means she didn't have any children, you are finding a short cervix. You are finding suggestive of incompetence. We don't go ahead and put a cerclage. We don't go ahead and do it because this cerclage also has its negative points. Okay, even putting the cerclage itself may hasten the abortion. So we have to select our patients well. And nowadays, luckily, we have progesterone. We have the sustained micronized progesterone, which is given, and this also relaxes the uterus, giving excellent results. So as I told you, each case is a case by case we decide, and also we it dictates how we dictate our management is history, ultrasound findings, and also how about the patient.
Right, ma'am. Next question is, how do you manage cases of slow or arrested cervical dilation in patients, and what are the preferred interventions?
See, there's nothing like slow or arrested dilatation. Okay. Now, either the cervix is dilated or not. These are all I'm talking about when the pregnancy is early. So, if there is a doubt of it, better to ask your seniors, better to ask a senior professional and then only do a circlage. Because as I told you nowadays, we are not doing circlages unless it is indicated. Okay, unless indication, clear cut indication is that we are not doing this. We are managing most cases with progesterone. But as I told you, this abdominal cerclage, laparoscopic cerclage, all these have revolutionized the treatment. So there is no case of slow cervical dilatation. It either dilates or not. But what we can do is, if the patient is high risk, do serial transvaginal ultrasounds, and then decide whether she needs a cerclage or not.
Right, ma'am. Ma'am, moving on to the next question. Ma'am, what is the role of pharmacological agents like oxytocin or prostaglandins in aiding cervical dilatation, and how do you assess their effectiveness?
See, I think this person who's asking is about patient in labor. Okay, I think what they're asking is, if the patient is in labor, how do you hasten the labor, or how do you assist in dilatation? Now in this there are many for pharmacological dilatations. What we are doing now, there's both mechanical and there is the drugs. First, what in our hospital what we do is, in case you want to dilate the cervix, we put Foley's. Then next time we supplement with the propes, that is dinoposin, that is the prostaglandins. That's what we are doing in our hospital. But otherwise, what we can use prostaglandins, or in olden days we used to do oxytocin, but nowadays there are better drugs. So in few centers, yes, oxytocin is being used for cervical dilatation. Okay, I think this person has asked for patients in labor.
Right, ma'am. Thank you, ma'am. Thank you so much for answering this query. We have one more question. What complications can arise from rapid cervical dilatation, and how do you mitigate this risk in high risk pregnancies?
Okay, see, rapid cervical dilatation can sometimes occur. It can cause tears. Okay, so if cervix is not competent, if the patient goes into labor, it will start tearing. So you may not only have to deliver the pregnancy, you have to also suture up the cervix. But otherwise, you have something little later in pregnancy called precipitate labor. Okay, that is the whole process. Labor takes many hours. The cervix is about 10 centimeters, it takes about 1 centimeter or 2 centimeters per hour. What happens is sometimes it's called the whole process of all the stages of labor is over within 2 hours. So that process you really cannot prevent. But this, in case patients are having precipitate labor, please be careful, deliver them in a hospital. If they're giving previous history, look for it and also treat appropriately.
Ma'am, there is one last question has come. Can I please go ahead?
Yeah, yeah, sure, sure, no problem.
Okay, ma'am. Um, how do you approach cervical dilatation in case of labor induction, particularly in women with an unfavorable cervix? Or in bracket, he
Okay.
has written low bicep score.
Bishop score. See, now the thing is, these questions are all come from, I think, students who are going who. Okay, now this patient is in labor, so your patient is having unfavorable cervix, means low Bishop score. Okay, now when we decide to induce a patient, we do this Bishop score. If it is low, we have to ripen the cervix. Now, ripening the cervix, as I told you, can be done by mechanical or by drugs. In our hospital, what we do is we first give mechanical and then we give drugs like oxytocin, or more commonly we give prostaglandins. These are showing beautiful results. So what we do is we give it, we reassess, and give the patient the full benefit of the drug, and only then we think of taking up a section.
Right, ma'am. So these were all the questions for today. Thank you so much, ma'am, for putting up your effort
Yeah,
and your time for making such presentation and like answering all the queries and solving the queries. So, ma'am, thank you from the bottom of my heart. And it's the way you have made this a complex topic into a very simpler one, and you have explained the things that was really nice. Thank you so much for your time and effort, ma'am. Once again, thank you so
yeah.
much.
My pleasure, Arpita. Thank you so much.
Thank you, ma'am. Thank you. Thank you all for attending the session. So, with this, we are closing it for today. Thank you all.
Thank you.